There's no one there.
Norma, I think you took over the hosting. Would you just start? Just give me a sec. We'll just start just now. Seems like Norma is not there on that side that I want her to. Just give me a second. But the numbers are counting in, so we are live. I think you can start. I'll just do the disclaimer again. Dr. De Bruin, you're welcome to start talking. It's fine.
Good evening to all the dental professionals who have logged in for this evening's webinar with Prof Peet van der Vyver, and thank you to SADA and Peet for presenting tonight's topic. While we're waiting for more delegates to log on, I'll go through some of the announcements. Please refrain from using the raise hand icon, but rather type your comments and questions in the Q&A tab. We will be addressing these questions after the lecture. CPD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your member profile. If you're not a SADA member, you will be able to create a profile for yourself and access these CPD certificates. This event qualifies for 1 clinical CEU, and we are streaming live on YouTube as well, so if you can't access the Zoom platform, find us there. We'd also like to just give you a reminder of the upcoming SADA events. On the 11th of May, we have an evening of ethics hosted by Dental Protection. And on the 12th of May, we have, while celebrating our receptionists on National Receptionist Day, a webinar hosted by Ms. Sunny Makatla and Dillian Slabbert, in charge of the practice's remote control. I also ask if you can kindly complete the evaluation after the webinar. We also have a surprise for this evening. There will be 2 questions asked during the presentation where you can win a prize, kindly sponsored by Dentsply and Equity Dental. The first will be a prize for 4 packets of files of your choice and AH Plus cement from Dentsply, all to the value of 4,000 Rand. The second will be 1 packet of magnifying mirrors and handles and a packet of high-resolution mirrors and handles from Equity Dental. These questions will be asked during the webinar, so please answer your answer in the Q&A box and add your name. Please no anonymouses. And with that, I'd like to present our speaker for this evening, Prof Peet van der Vyver, and his topic is Mandibular Premolars, Anatomy and Endodontic Management of Complex Cases. Over to you, Peet.
Thank you, Ms. D. It's really a privilege to be back on the SADA webinar program. I'm also privileged to have a host that is my partner, Misty, in our practice, Studio for Endo and Resto and Education. And I'm also going to share some of Misty's cases tonight with you. So when we get to Q&A, we can actually both answer the questions. So the numbers are still coming in. Thank you very much for everyone that is willing to share the evening with us tonight. Let me move over to my slides. Just want to get all my panels organized here. Something is kicking me out. I don't know why. That's quite weird. Let me just share again. Marilisa, I don't know if you can help me. I've never seen this. If I share my screen and I go play, it just kicks me out again.
Norma, can you step in and assist, please?
It's very
Hey,
weird.
doctor. Try, doctor.
Hi.
Let's see what's going to happen.
Say again, sorry.
Try one more time.
Okay, let me just stop sharing. So we tested it before the time and it was fine.
Try again. Let's see.
There's a message that comes up here to share your computer audio. Please install a Zoom audio device. I've never seen that in my life. Please restart your audio share application such as media player. Cancel. Let me just take my microphone. See what happens.
Do you have an extending screen with you? Because sometimes I find that if you're using two monitors, it would say that.
Yeah, I've got extending screen, but it's disabled. Okay, there we go. That was my audio.
I can see your screen find this end. Let me see what's happening on YouTube.
It was my audio. Don't worry. Let's see if it will come back.
Great stuff.
Just again, yeah, my audio. Okay, there we go. Okay, cool. I apologize for that. I don't know why it's doing that. Right. Can you just confirm you can see my screen, Nama?
I can see your screen, doctor. Go ahead. Thank you.
Okay, cool. Okay, ladies and gentlemen, I apologize for that. Welcome to this webinar where we talk about the anatomy and the endodontic management of mandibular premolars. Firstly, as you know, I'm affiliated with the University of Pretoria and also the chairperson of NOMADS, the South African Society of Endodontics and Aesthetic Dentistry. And I will also share with you one or two new things that we're doing on this front. And then also the third logo here is our practice logo for myself and Misty, where we run the stereo for endo, resto, and education. And as you can see, we're quite active on the education platform. So tonight's agenda is going to be as follows. The things I'm going to address is firstly tips and tricks that I'm going to share with you to identify additional canals in mandibular premolars. Most of the time you can pick these up on a periapical radiograph, but today with CBCT it's much easier, because if you have a CBCT scan, then it's quite obvious that there's more than one canal. But we have to take into account that most of you don't have CBCT, so I'm going to share with you a few tips and tricks to identify additional canals in mandibular premolars. We'll talk a little bit about the anatomy of the first and second mandibular premolar because they differ. We'll highlight the importance of ultrasonics and instruments and magnification, and also clinical case reports. So by means of clinical case reports, I'll illustrate what we are going to discuss. So here's our first prize that Misty has highlighted already. And the question is, what is the incidence of a mandibular second premolar to have 3 roots with 3 separate canal systems? So you guys can type that for the next 5 minutes into the chat box. And the first person that answers correctly, Misty will identify, and then we will come back to you later on and request your details. So I'll repeat the question. What is the incidence of a mandibular second premolar to have 3 roots with 3 separate canal systems? And this prize is from Dentsply Sirona. You can choose 4 packets of files of your choice, and you'll also receive an AH Plus cement kit for free. So what I'm going to share tonight is cases from myself and Misty on the left-hand side, and also the previous person I did endodontics in my practice, Verana Pelliker, and she's now currently in Manhattan in New York. Now you can see that we photoshopped this picture. This is how we're all going to look when we're 10 years older. So I think you can see what this looks like, quite a promising event that we can have a nice celebration in 10 years' time, looking much younger than what we look at this stage. I'm going to mainly discuss one article that I wrote many years ago in endodontic practice in the UK. If you want the article and some of the cases that's inside my presentation, you can go to our website, www.stereoforendo.com. You go to the education button and you can look at management of complex premolars, and you can download this article, and it will cover most of the information that I will present tonight in this webinar. I also told you that we're going to launch some new things for nomads, and we're launching a lot of hands-on workshops. We're going to go lots into the education front on workshops, and this is our first workshop that we launch on periodontics, and it's going to be the 31st of May, and you can go to the website and register there. There's only 12 space for 12 delegates, so you have to hurry up to be on this workshop, and we're going to have a lot of fun. So let's get to tonight's presentation and start with the first slide. This is from the Ingle et al. Study, and you can clearly see 1994. And in this study, they show that mandibular premolars have the highest failure rate of all the lower teeth that are root treated. Some articles are starting to show maybe more molars, but mandibular premolars has got a very high failure rate in the mandibular arch, and mainly because of variations in root canal morphology. Sometimes I speak to newly graduate students, and they all have the opinion that the lower premolar, most of the time, about 95% of times, will have a single canal. And then the other problem is it's difficult to get access into these root canal systems. It's much easier to find a MB2 canal on a maxillary molar than to find sometimes a second or a third canal in a lower premolar. So it's difficult to actually locate these root canal systems. Even if you know it's there, even if you see it on CBCT, it's not so easy actually to find and locate them and treat that root canal system. Here you can see Lofty 2008 said endodontic treatment can be a very challenging task because of the complex and variable anatomy. And lots of authors has highlighted the fact that we should carefully examine our preoperative radiograph to identify possible additional root canals. And before the advent of CBCT, or if you don't have CBCT in your practice, you can see these articles are not recent. It's advisable that if you treat a lower premolar, that you have a 30-degree mesial and a 30-degree distal angulated view to try and alert you that there might be additional canals. Firstly, Rodvik and Hulsman told us that we can carefully trace the exterior and the interior outlines of the tooth, preferably with magnification. If you have an analog radiograph, if you have a digital, you can enlarge it on your screen, and you can emboss it, you can colorize it, you can invert it. There's lots of things you can do to help you actually to identify additional root canal systems. So let me share with you quite a few other things that you can look at that should alert you that you're dealing with more than one root canal in a mandibular premolar. The first one, suspect additional root canals when an instrument demonstrates eccentric direction on penetration into the root canal. So if you place the instrument, you take a radiograph, and you can clearly see here, you expect the file to go straight down the middle of this root, and you can see it's eccentric as it deviates from the coronal aspect. So that should alert you that you might have to look for an additional canal. This is probably the key thing that you should look for: sudden narrowing or even disappearing of the pulp canal space. So you can see the pulp canal space up to this level, and then it disappears. It looks like the root is calcified. That's a clear indication, not just on premolars, but on any canal, that there's probably at that point it will diverge, it will split into two, it might remain separate, or it will merge back at the apex of the tooth. Another thing for premolars, you can suspect the additional canal when a mid-root image diameter. So if you take a radiograph parallel view and you look at the mid-root image diameter, and that is wider than the coronal aspect of the tooth, then you must also think of having additional root canal systems in this tooth. Suspect additional canals when working length radiograph display instrument that is off center. You can clearly see here, you would expect that it goes through the middle, but it's clearly off center from the mid-root area. Good tip that you are dealing with multiple canals in this root canal system. Another one, if you see radiolucent lines on your radiograph, and also if the file is definitely a little bit off center. On this case, you can see it's really not off center, maybe a millimeter or two, but you can clearly see my blue arrows there. There's a radiolucent line there that might indicate additional root canal system. And as I said before, with CBCT, it's a lot easier, and I will share some of the cases. I will show you the CBCT scans. It's a great tool to evaluate canal morphology. The article by Mathurner et al. In 2008 told us that you can detect a lot more root canal systems. You can detect a lot more pathology. And there's a lot of magnifying and identification tools in the software that you can actually use. So the first thing I want to talk about tonight is about vision, because remember I told you that it's quite difficult to detect these root canal systems. So we need good vision, unfortunately, to treat these root canal systems. And here you can see a quote that I like to show from Jonathan Smith that said, Swift, vision is the art of seeing what is invisible to others. And that is exactly what happens in these premolars. When the information is invisible, people assume that there's only one root canal system in these specific teeth. So we need high magnification. We don't always need a microscope. We can also get away with loupes depending on the type of case we're dealing with. What is important, we need bright illumination. And that provides us with very valuable information inside the pulp chamber. And also it augments your visualization process. So it gives you a lot more visual information. So you can have a set of loupes that's 2.5, 3 times magnified. You can look at the 4 times magnified loupes. For instance, the Zoomax company sells a 4 times. Great tool to use for locating additional canals. And I'm going to show you some cool mirrors in a moment, that if you have loupes and you have magnifying mirrors, you probably at the vision level of sometimes an entry-level microscope. So depending where the canals bifurcate will dictate the level of magnification, and we'll talk about that in a moment. Here's the mirrors I'm talking about. It's high resolution mirrors. You get Zirk mirrors, and you get these HR front mirrors from Ruder that is sold by Equity Dental, and the Zirk mirrors are sold by Inter-Africa. These are great mirrors to have in your practice, not just for endo, for any restorative procedure, because you're going to see a lot more detail. And these mirrors reflect 97% of the light back. You get different sizes, so the further you go back in the patient's mouth, especially for endo, you need smaller mirrors. There's different sizes available. Remember, a normal standard rhodium mirror loses about 30% of your overhead light. And if you're working with halogen and a normal mirror, you don't have really good illumination of on your field of on the field that you're actually trying to magnify or trying to look at. And then there's also magnification mirrors available. They go up to 4.5 times. If you work through the microscope, for instance, you get double vision in them. But they're great to just look at the margin, to look if you want to locate the canal, for instance. You can't work all the time with them. But if you have 2.5 times loupes, and they work better if the light is in the same site of what you're actually viewing. So if you have direct light, for instance, on your loop system or on your microscope, it works a lot better than having overhead light on these mirrors. But really a great tool, not just for endodontics, but for restorative dentistry. The other thing you can look at is the pulp chamber anatomy. Check if it deviates from normal configuration. If the pulp chamber is very wide in a mesial distal plane, then you must suspect additional canals. Or if it has a triangular shape, there's usually more than one canal inside the root canal system as well. You can also suspect a third root canal if the pulp chamber does not appear to be aligned in its expected buccal-lingual relationship. Here you can see where the red arrow shows my conventional buccal-lingual relationship, and you can see that this pulp chamber is turned a little bit about 30 degrees clockwise. And that usually, if you have 2 canals already, and you see this configuration, it usually alerts you, according to Roddick and Hulsman, that there might be even a 3rd canal present in these root canal systems. So coming back to the complexity of the case, some of them will split coronally, some of them mid-root area where the bifurcation is, and some of them apically. And obviously, the higher up it is, the easier it is to detect with less tools, less vision. The more deeper the bifurcation is, the more illumination you need, and the more magnification, and the more skill and the more experience you will need to manage those cases. So here you can see my diagram. If you're dealing with scenario number A, you can probably get away with loops, maybe good mirrors. If you're dealing with situation number B, mid-root bifurcations, you need to up your level of magnification, maybe to 4 times loops or 5.6 times, just for that period that you want to locate the canal system. And if you're dealing with trifurcations or bifurcations deeper down in the apical third, then you're going to probably need microscope magnification to about 19 or 20 times. But luckily, most of the cases that you'll see when I show you the cases tonight, most of them are probably A and B. So I don't want to tell you that you need microscope magnification just for treating lower premolars, but you need some form of magnification and obviously good illumination. So let's talk about the mandibular first premolar and look at the anatomy of that. So 70% is a single canal. So that should scare you already, because 30% of premolars that you treat daily in your practice has got more than 1 canal. So 30% has got a single canal, and you can see some examples here. These examples are not prepared. They are micro CT scans from Erika Branson from the Tooth Atlas, and these are unprepared canals. This is the buccal view, and that shows you a mesial view to show you actually how lint form the canal is. And here you can see examples on the right hand side, and most of you will probably agree that I probably think in my first 10 years of practice, I probably assumed that the mandibular first molar has got 90% or 95% a single canal. 24% is 1 canal that bifurcates in the apical third, and sometimes very low down. So you can't really treat this even with a microscope. If it's a short route, yes, you can locate it, you can prepare it. Sometimes if it's a long route, you just have to depend on irrigation to actually clean that bifurcating area and obturate it with heat. Now here comes the difficult parts. 4% has got 2 canals joining in a single foramen. It's not a common form. In fact, I don't have a good example of this in my practice actually, but quite tricky to treat. Very dangerous join here, high risk area for foul fracture as well. Usually try and prepare the straightest one first, and that's where CBCT helps you a lot, because you can distinguish which one is the more straight route and which one is the bifurcating route. 4%, 2 canals joining in a single foramen. 1.5% will actually have 2 independent canals, and they usually split about coronal third or mid-root area. And then what's rare, and the mandibular first premolar would be 3 root canals, not very common, and also you get C-shaped root canals, also quite rare. So you can see that the mandibular first premolar has got quite complex anatomy, but that's not where it ends. It actually gets more difficult than this. Some of them has got 2 roots with 2 separate canals in independent roots, and that's luckily low, but that's 0.5%, but you have to be aware of this. There you can see some micro CT examples, and then you get very rare cases where there's actually 3 or 4 roots. And you can imagine these are quite tricky to treat, especially if it bifurcates quite low down. And this is very rare. This is about 0.2% of cases that will present like these examples. Now, let's go to some clinical cases. The first case I'm going to show you that Misty did a few years ago, and this was the preoperative radiograph. The dentist identified that there's problems. We didn't have a CBCT at that stage, so but from the experience, the dentist suspected that there was a second canal and that there's also a large periapical infection. And this is how the case presented to us. There was the access cavity. So a first file, just to check where the dentist went in, you can see clearly that the file is eccentric. So clearly showing us that we have to look for more root canal anatomy inside this tooth. It's quite critical to locate this additional canal in this case because of the large periapical infection. If it was a virgin tooth, no periapical infection, you're missing the canal, maybe they join, you can probably buy a few more years. But that's probably at the point there that we suspected where the bifurcation is from the radiographs. And I'm going to show you an example of a diagram of what we're actually looking at inside that root. And you can see this is usually how it looks. So it deviates off the main canal. So if you put a file in, it goes straight down and it deviates sometimes about 30 degrees, sometimes 60. I've seen cases that's nearly 90 degrees that it actually comes out of that area. So in order to locate it, you have to remove tooth structure in this area where the arrows are indicated. So that means sometimes that you have to increase your access a little bit more. And I find that a good tool for this is the StartX tips. These are not flimsy tips. They last very long. They're very, very strong unless you put them in a very high setting on the ultrasonic scaler. But for these type of bifurcations, I like to use StartX number 1 for the simple reason that StartX number 1 has got cutting flutes on the side, but it's got non-cutting flutes, no cutting flutes at the bottom here. So if you're scared of a furca area or something like that, you won't perforate there. But just to realign that, to take that amount of tooth structure away there, to allow you access into the second canal, StartX number 1 works actually very, very well. You can probably also use StartX number 2. Again, the higher level of magnification you have, the more safer you are. But these are the recommendations for dentists that probably works with loop magnification. I would put in this case, I would put a StartX number 1 because I just want to widen this area a little bit to get access into that canal system. So there you can see a high magnification view where Misty has actually done that with the StartX tip. And that is our canal that was negotiated before. And here you can see some evidence there will probably be a canal in that area there. And with C+ files, we went in there, and there you can see the second canal. That one actually looks more centered. There's the 2 files. Both canals were located. She prepared this with the ProTaper Universal System using PAR file still. Cone fit photo, activation with endoactivator, sodium hypochlorite heated, and obturation with the calamus. And interestingly enough, you can see on this post-op radiograph that in the one canal, there's actually a bifurcation and another line of cement running down there. So there's even a bifurcation in one of those root canal systems. But quite a nice post-operative result. We never saw this patient again, but I'm sure the periapical pathology healed in this case with this excellent result that she achieved. I'm going to show you very fast a few cases. You can see a premolar next to an implant on a 30-degree angulated view. I could see the 2 canals clearly. Can you see how powerful that view is? That we have to do mesial and distal views for these teeth. On the pre-op parallel view, it looks like one single canal. By just moving that beam 30 degrees, I could immediately see that these 2 canals. Excuse me. Now, after a few attempts to actually get into that second canal, here you can see a radiograph where we can actually see the level where it splits. You can clearly see there's a radiolucent line there. So a few times I tried with micro openers and files to get into that second canal, and I just couldn't, because you can clearly see what we're dealing with. It's like a 90-degree exit, and this is how most of them actually exit in the mid-root area. So here we want to actually remove tooth structure sideways and also make this area a bit wider so that we can get penetration of our files or a micro opener into that area. Now, these are very useful tools that I would suggest you use not just for premolars, but for any teeth to locate canals. And the two things I'm going to show you is micro openers. They are in different sizes, 4% and 6%, and also size 10 and 15s. The cutting flutes are 7 millimeters, but it's basically a hand file on a handle. So the beauty of this is when you have the file in the canal, you don't have your fingers obstructing your access. So you can still see where you probe, and they are beautiful little instruments. And I'll show you some video clips in a moment of how I use these instruments once we located the canals. And then if you want to open up a little bit more or more aggressive in that canal space that you've just located, I suggest you looking at the micro debrider. These are not K files, but they are headstrong files. They're actually to remove debris from the canal, like gutta percha, but they work brilliantly for filing that access into that newly found canal. If you allow me to go back, like here, if you manage to slip that micro debrider in there to file that amount of tooth structure away there, the micro debrider works a lot better than using the micro opener. So that's why I'm showing you both tonight. But my choice here would be either the StarTex number 1, or here I actually want active flutes at the tip because I want to cut that dentine away where number A is, and at the same time widening the canal a little bit. And this is why my choice would be a StarTex number 2 tip, because I can cut right at the tip where the bifurcation is suspected and also widen the canal coronally in order to locate that orifice. And you can see, once you've used StarTex number 2, I could easily penetrate with one of these devices into the second canal. So here again, mid-root area, we need magnification, we need LED illumination, and the micro openers and debriders are quite useful. The micro opener is more for detection, and the debrider is more for filing that dentine ledge away. So there we've just located it. There you can see my view through the microscope here. It's quite far down. There goes the micro opener in. And what I do then, once I feel that I've actually gone into the second canal, I use a very slow sawing motion by moving that debrider controlledly up and down without pulling it out of the orifice. And you do that 4 to 5 times or 6 times, and you can see there's my orifice next to the liquid that you can see in the main orifice, just there where my pointer is now. That's where the second canal orifice is. And if I now jump in with a micro debrider there, I can very quickly remove restrictive dentine in that area. So this is what we wanted to achieve, more straight line access into both canals. There's my final length determination photo. I've used Vyver 1 Gold in this case, and there's my final obturation radiograph. Here's another case, also 2 canals joining. Remember, I said to you, I don't have a lot of them. This is the only one I probably have. 4% incidence where 2 canals join in the apical third and ending up in one canal. This case I've prepared with Vyver 1 Gold, but the yellow file. Today, I'm hesitant to prepare with the red file like I did in the previous case if I have multiple canals in a single root. So I rather would use the Vyver 1 Gold yellow file. Now, let me share with this case with you. This is quite an interesting case. The patient came in, was in a lot of pain. We took a CBCT. The bone looked fine around the tooth. You can see it's got a very strange configuration on the CBCT. There you can see there's maybe a bifurcation there, and that split was about 10.2 millimeters down the canal. So this was the access that the dentist made, and in this case, it's also one of those configurations of 2 canals joining with a single foramen. There I'm using a micro opener, and I've also used the StarTex number 2 tip to take a little bit of that dentine away to facilitate penetration into that canal in a more straight line. You can see I'm using the StarTex tip. Ultrasonic scaler, about a setting of 4 to 5. You can't put it too high. then you will damage the ultrasonic tips. But there you can see we've got nice straight line access into both those canals. Here's my micro opener again. It looks quite like a large instrument because it's a magnified view, but you can see I'm using it again as a little saw to make my way in a more straight line into the anatomy of that second canal. And here we've got both files in, they join in the apical third. We obturated the case, we irrigated, and everything looked fine. 2.5 weeks later, the patient phoned and said, there's a swelling next to my tooth. I took a radiograph and I could see the bone doesn't look very good on the mesial aspect here. And there you can see we even filled some lateral canals as well. And on the CBCT view, in 2 weeks, we've lost all the bone on the mesial aspect of this root. There was no bone left on the mesial aspect. Cortical bone, yes, but soft cancellous bone was gone. So there was nothing else to do because the tooth was floating in thin air, and we decided to extract this tooth. And on the closer examination, you can see that there was a crack in this tooth that I could not see from the inside during canal preparation. But just to show you that, look how far this crack goes down. And there's a higher magnification view of these cracks. And this is the problem that we're dealing with in teeth. And this was probably the reason why the tooth became or had irreversible pulpitis from start before the dentist even started the root canal treatment. Now, you probably all know that we can't see these cracks on CBCT. So we extracted this tooth and we took it to Nexa, where we can drop the resolution. So this is a 30 micron scan, and you can clearly pick up now and appreciate the crack that we saw on the extracted tooth as well. It would be great if our CBCTs could go down to this resolution, because I think it will solve us a lot of headache in our practices, because we can only see on CBCT cracks that are actually displaced away from each other. These micro cracks we cannot observe on our 75 microns, or some of you work with 200 micron CBCTs that you can probably not even see the canal systems. But look how far that crack runs down. And let's just talk a little bit about this, because the first question you're going to probably ask me is, what caused the crack? I think the crack was there from start. There's lots of speculation in the literature that it might be from root canal preparation systems. Some of the studies show more chance of cracks forming with multi-file systems. There was 2 studies by Bertline that showed it's reciprocating instruments. Although we know those studies weren't done properly because they used a size 4008 file to prep a lower central incisor. But to put it all into perspective, I think this is quite a good study. The one from the Diaz, Journal of Endodontics 2014, where he looked at the relationship between microcracks and canal preparation with reciprocating and with rotating instruments like the BioRay system. And what the Diaz has showed us is he basically said all the studies we read in all the journals are a lot of garbage, because they prep the canals and then they micro CT scan them, and then they see cracks like these, and they tell you it's the file system that caused it. And he caused a lot of havoc with the study, because he said there's no causal relationship between microcracks and preparation. And how he proved that is he pre-scanned the teeth before the time, and he showed that most of those cracks were actually there before the root canal preparation. So just keep that in mind. Here's some more views of that micro CT view. You can see that the crack is running from my canal right to the external surface of the tooth. Let me show you. I'll show you another view in a moment. So I want to highlight this study. This is a study by Rosa Silva that recently was published in 2021. And she showed that if we look at vertical root fractures, it's usually if there's less than 1.3 millimeter of surrounding dentine around your root canal preparation. Whereas the non-fractured ones, the ones that didn't fracture, she showed 1.5 or more. So you can clearly see the larger your preparation size, the more safe, the more weaker the root is, higher risk for fracture. And that's why the new true anatomy system that's got a maximum fluid diameter of 0.8 is showing such a lot of promise. Here you can see, if you look at the scale at the bottom, that's 1.5, not the blue line. the other line there. So that is actually less than 1.5. So it's 1.3. So that actually correlates with her study. And here's some more CT views. So we've got about half an hour left, so I'll have to start moving on. But let me share with you the take-home message when you treat lower first premolars. 70% is one canal, 24% of them can bifurcate in apical third. You cannot always treat that. 4%, I've shown you 3 cases now, 2 canals joining into a single foramen. And then the more rare stuff that I'll highlight separately, 1.5% of them can have 2 independent canals, 0.5% 2 separate canals in 2 independent roots, and 0.2% of them can have 3 or 4 root canal systems in the same root, and they are quite rare. So before we talk about the second premolar, let's look at a question again for your second prize that we're going to give away. And remember, I talked about the mirrors, and I told you what is the percentage that it reflects the light back. And this prize is normal high reflective mirrors with handles, and also magnifying mirrors with handles. And that's worth 2,000, I think 2,200 Rand, around there, that you can get from Equity Dental. So the first person that posts the correct answer again to Misty on the Q&A box will receive this prize from Equity Dental. Right, so let's talk about the mandibular second premolar. Here you can see that the percentage is slightly different, not 70%, but 65 to 100% can have one single canal. I think the norm here is more a single canal than multiple canals compared to the mandibular first premolar. But in certain cases, it drops to 65. So you see that there's quite a lot of chance for multiple canals as well. 1 to 11% of them can have 2 canals. And if there's 2 canals, they can either have in 91% of cases 2 separate apical foramina, and sometimes more apical foramina in 8.2% of cases. So let's look at this case report. I've showed you this picture before where we saw radiolucent lines. So we suspected more canals. We took a CBCT, that is calcium hydroxide in there, and there you can see the additional canal sitting on the other side. Now, let me show you the benefit of having a high definition CBCT. This comes from the Carestream machine that's on 75 microns. Now I'm showing you 1 millimeter, probably 1.2 millimeters of slices here. Look at the image on the right, and I know we're on Zoom, so you might not see exactly what I'm showing you, but if you look very closely, you'll see that I saw 2 canals. Let's just go back here. I saw 2 canals right down the root, but at a certain spot, I saw 3 canals. And if I scroll 0.25 mils down, that dot moves to the root surface. And if I scroll another 0.25 mils down, I've got 2 canals again. And that means that we have a lateral canal. It's not an additional canal. It's purely a lateral canal. So I think you can appreciate how easy it is to treat any tooth with a CBCT, because you can see how many canals there are. You know if they deviate, you know if they curve, you know if there's lateral canals. Most of the time, Debbie, my assistant, will tell me before the time, I think there's a lateral canal in a palatal root or in a mesobuccal root. And then the heat is on because I have to deliver that. Because she knows it's there, she can actually see it. So let's see how this case worked out. So I first located the second canal. There you can see the orifice there. And I had 2 main canals that I prepared. Here I've used wave 1. I think it was still conventional wave 1 in this case, because if I look at the cones, there's my cone fit photo. This is in a category of 1 to 11% that they will have 2 canals with more than 1 apical foramina. And here we have a problem, because when they bifurcate so far down, it's very difficult to get 2 cones next to each other for obturation. And often here you have to remove additional tooth structure with the ultrasonic tip to get these 2 cones in. Today with True Anatomy, this is amazing to treat these cases with True Anatomy, because the cones are a lot slimmer and you don't have to sacrifice this additional tooth structure with the true anatomy system. If you look at a true anatomy red cone versus a ProTaper universal or a ProTaper next or a wave 1 cone, it's probably a third of the thickness. But when we use tapered cones, like any one of the systems I mentioned now, you often have to remove additional tooth structure here to actually get the 2 cones next to each other for obturation, because you can't obturate the first canal because then it blocks you out of the other canal. So you need those 2 cones in at the same time. And here you can see my downpack. I've just downpacked here with Calamus Dual. That was before the Gutter Smart system. And no surprise, we've got a lateral canal exactly where the CBCT showed us. So you can see how accurate our information is on CBCT. Now, if we move on with the second premolar, 0.4% of these cases can actually have 3 canals. And this was quite a challenging case to negotiate, or both of these cases. And I'm going to show you this case in a lot more detail. I think it's the next case report. So this is how the case presented. You can clearly see here the clues already. A big canal space, and then it disappears. So the dentist that sent me this case said he can't get into the canals. He thought the canal is blocked there. But that's a clear-cut clue to tell you that there's a bifurcation there. And a very large periapical infection here, right next to the mental foramen. So that's how the case presented. You can see I've opened up the access a lot, and I didn't have a preoperative scan in this case. I can't remember for what reason we didn't do a scan, but we managed the case up to a point. But I've got a post-operative scan that I can show you. So there's my first file. It's a C+6 file. You can see it deviates from normal anatomy, and it's blocked in the apical third again, but that was my first file that penetrated in. Here we picked up StarText number 2. We moved a little bit into the other direction, located the second canal, and we used the orifice opener again like a little saw up and down to facilitate more straight line access into that area. But you can clearly appreciate the view. I apologize, I put this microscope view now right over the video. But you can clearly appreciate what level of vision I have down this canal. And it's probably about 8 to 10 to 12 millimeters. That you can't do this without proper illumination and magnification. It's just not possible. You need, at least in these cases, probably 4 times loops and magnifying mirrors to see that amount of detail right down the canal system. So here's my second canal that I located, and by chance, when I pushed these files in and out, I felt there was like something hooking on a different spot. So that alerted me. If I had a CBCT, I would have probably had a roadmap from start. But yeah, I was working a little bit blindly. So it prompted me to go in further and look for another canal. And this pulp chamber was also triangular when I looked down with the microscope. So yeah, I'm very deep down the canal now. I'm halfway down the route. So here my choice would be a thinner ultrasonic tip. So here I'm choosing StarText number 3 because I'm at a deeper level down the canal. This is a great ultrasonic tip. If you buy one tip of the set, I would probably choose this tip. But just make sure that you don't go too high up on settings because it's less metal. It can easily fracture if you put it on a setting of 8 to 10 on your ultrasonic unit. But a very robust tip. In fact, in the last, probably, if I have to guess, in the last, I don't know how long StarText tips are out on the market, I would probably guess about 12 years. I've broken, I think, 2 of them. One I rode over with my chair. It bent. I bent it back, and eventually it gave up. And probably last month, I broke the first one because I put the scaler on too high. I was on 12 and I didn't see. I came from a scaling episode right down to StarText that I wanted to use it, and I forgot to set it back, and the tip just went. But using it on 3 or 4 power, it's a lifetime tip that you can't destroy really. So there's the view through the microscope. You can see it's triangular, and I troughed more on this video. I'm troughing more a little bit distal from that orifice where you can see the shiny spot. That's where I suspected the other canal is. So 2 buccal canals here, and 1 more canal more located to the lingual aspect. And there you can see there's the orifice of the third canal. So there's my 3 files. I negotiated them to length with C+ and K files. That took me quite a while, but you can see they all join right at the apex into one canal again. There's a high magnification view. We used ProTaper Universal in this case. It's quite a long time ago and still PAR files that we won't do today. But there's my obturation. A 3-month healing, you can see the lesion is getting smaller. And a 6-month, we've got probably about 70% of the area healed. But look how interesting the CBCT is. Here you can see coronal. There you can see mid-root area, where there's the 2 buccal canals are still joined and the lingual canal. And then if we go a little bit further down, we can see 3 canals. A little bit further down, 3 canals. Then 2 canals, and then they join up into 1 canal right at the apical part. So let me show you a few more cases before we move on to the next example. Lower premolar. Someone treated a single canal here. On an angulated view, I could see cement went into another canal. And when we started treating it, we found that there was 3 canals. Here we treated with wave 1 gold. And there's our post-obturation photo. So if you look at that root before on a parallel view, it looked like one single root. Just looked like it's poorly treated. But you can see that CBCT gave us a good clue here that there is multiple canals in the system. Here's another interesting case, a heavily restored tooth, very short premolar, but the scan showed us 2 canals. Sorry, 1 canal there, 2 canals. Very funny root canal configuration, and there you can see 3 canals, and then it drops down to 2 again. And I apologize if you can't see it because of the quality. Maybe that zoom loses on the slide, and right at the tip you can still see 2, but very, very close to each other. But that was the first 2 files or 2 canals that I located. Because of the scan, I knew there's a 3rd canal. So it took me quite a while to locate it, but I only could locate it partially. I couldn't get patency in it. So eventually I gave up there. And when I did my glide path, I felt that the file moved a little bit further in and it joined into one of the other canals. And here you can see my post-obturation photo. And on an angulated view, we see even more. We see the 2 main canals, the canal that curves in, and another loop that we actually irrigated through chemical irrigation, that it was actually cleaned and obturated. So you can see quite complex anatomy in this tooth. So another thing that you can get in mandibular second premolars or incidents is 4 or 5 canals. I don't have a case for you, but there is cases in literature. On that same case, I've just shown you 2 cases back where the 3 canals joined. If you look at the first premolar on the scan, it's actually got 4 canals. Look at that. There's a dot there, a dot there, a dot there, and a dot there. So it's quite amazing to look at these CBCT scans and see sometimes not even the tooth you treated. The first thing we usually look for, myself and Debbie, is if the canine has got 2 roots or 2 canals. That's quite common if you look at scans. But on this case, you can see a first premolar with actually 4 canals. So the second premolar can also have 2 separate roots. About 0.3% of cases will present like that. This is a case that my previous partner before Ferdinand Palager, Louis Ventler, he's now he eventually qualified as an endodontist in Australia, and he's now in Tasmania. This was one of his cases that he did while he was in my practice, and you can see there's also a lateral periodontal cyst that we removed after the obturation. And yes, just the case from literature. It's not very clear on Zoom probably, but 2 separate roots in that case. Here's another interesting scan of a root premolar with two roots. They bifurcate mid-root area. The dentist only treated 1, and you can see that the case has failed. And if you look at the CBCT slices, you can clearly see the other root. Here's another case that actually came many years ago from a prosthodontic practice where they could only find 1 canal in this premolar, but on X-ray, not even on CBCT, we could see the 2nd canal. So it's not easy to get down these canals because you need magnification and vision, and the more you do of these cases, the more experience you actually gain. But here you can see the scan, quite a large area because the one complete root was missed. And there you can see the other canal. We went in under magnification. We found another canal, and in fact, I found a second canal in the other root as well. And there was our final obturation photo. So I'm nearly at the end of my presentation. I think we're doing quite good for timing. I originally thought we will be maybe longer than an hour, but we are spot on time. So here's the first prize question was a mandibular second premolar. What's the incidence of having 3 separate roots? And the answer was 0.1% of cases. And see, Misty has texted me that the first correct answer was Natasha Andrews that said 0.1%. And can you please just type your contact details for Misty in the Q&A? If you don't want to do that, then just make contact with Dentsply Sirona tomorrow, and you can just speak to Berenice Miller and you can tell her that you won the prize, but we'll give you the names through as well. And then the second, the person that won the second prize from the mirrors is Richard Lombard. The answer to that was 97% of reflection back from the mirror, the light from the mirror. So you can also contact David Dubell from Equity, or you can post your contact details in Q&A and we will make contact with you. So ladies and gentlemen, let me share with you the last case that we have in this presentation. So this is Misty's case that she's done a few months ago. 3 separate roots, 0.1% of cases will have 3 separate roots. Now, let me take you through the CBCT. Usually, if you look coronally under the microscope sometimes or on magnification, you'll see on the buccal side that the tooth is very wide, like that type of configuration, like a little molar, in fact, that you can maybe identify there where my arrow is. But coronally, you can see it's one canal. Then if you drop down, it becomes more like a molar type of configuration. Mid-root area, it's split into 3 separate roots. Apical third area, and right at the apex, we still had 3 separate canals. So in this case, we also pulled it into the endo software from Dentsply Sirona. I don't think it's available anymore, 3D endo software. And here you can see the 3 roots quite clearly. It just helps you to plot your case, and you can connect the orifice with the apex, and you can get a simulation of how the canals actually curve or what the configuration is. And here you can see a simulation of what we're actually dealing with in this root canal system. So you can clearly see 3 wave 1 files, and will they manage the curvatures, and how acute the curvatures are, and do you have straight line access. So quite a challenging case to do, although the canals are quite straight. But with wave 1 gold, seeing all the giving us flexibility, it wasn't too difficult. So you can see a different length determination x-rays, the 2 buccal canals, and that one is in the lingual canal. There's the access cavity that she had. And then we did the standard protocol. For wave 1, we will make a size 10K file loose, and then follow that up with a wave 1 gold glider to prepare glide paths in all 3 canals. And then prep with the wave 1, probably 2/3 down, backstroke brushing motion a little bit, just to create more space. And then after irrigation and recapitulation, we take the wave 1 gold file right down to the apex. There you can see a cone fit. And then on this side, you can see the final obturation with one little lateral canal at the tip here. So this is quite rare, 0.1%. In fact, to be honest, I don't think I've treated one of these before. So I was quite jealous to see her treating this case. But hopefully my time will come. I've still got a few years to practice. But it's really fun to treat these challenging cases. So let's summarize. What is your take-home message about the mandibular second premolar again? Single root. 65 to 100% will have a single canal. 1 to 11% can have 2 canals, single apical foramen or multiple apical foraminal. 0.4% of them have 3 canals, and very rare will be 4 or 5 canals in the second premolar. And then very low incidence. Sorry, I just need to move my block here. 2 separate roots, 0.3%, and 3 separate roots, like the last case I've just highlighted for you, is 0.1%. So again, I want to invite you to attend our first periodontic workshops. It's a full day. You can go to the Nomads website and you can register there. The credit card payments is not open yet, but you can do EFTs. The credit card payments online will probably open tomorrow afternoon, hopefully. So with that, I want to thank you for your kind attention and hope that I've stimulated you to look at these premolars from a different angle when you see them in your practice again, and not just accept that you're dealing with a single canal most of the time, and also know that you've got a very high failure rate on these cases if you miss one of these root canal systems. So I really want to thank you for attending, and we will now go back to Dr. De Bruin for opening questions, and you're also welcome to direct questions to her regarding the cases that I've showed that she so kindly allowed me to share with you tonight.
Thank you again, Peet. That really was a very informative lecture. So we have got a couple of questions. So the first one is from an anonymous. In your opinion, should a GP dentist perform root canal treatments? And secondly, if yes, without CBCT, should they still do a root canal treatment?
Wow, that's an interesting question. Well, your first part of your question was, should a GP dentist do endo? Is that correct?
Yes.
Or premolar? Was it?
Well,
was
yeah, it just says root canals in general.
Well, firstly, there's no specialist really in this country, so we're all GP dentists. So I think my answer to you is going to be yes, you should be doing it. I encourage you to do it, but I also encourage you to use the right tools and to upgrade your skills, because that's exactly what we've done ourselves and what we've done with the Endo Diploma course that we run at the Pretoria. So you have to decide your level of skill. And then also, do you have the necessary tools? If you take my loops and my microscope away tomorrow, I won't treat lower premolars with multiple canals. It's as simple as that. And don't get me wrong, this is not a lecture to try and send cases to our practice or to any other endodont practice that is limited to endodontics in South Africa. I'm not discouraging you to do that. I would rather encourage you to learn more and to actually buy this equipment and enjoy dentistry more. What was the second part of the question? CBCT.
Well, if you don't have a CBCT, should you still do
Yeah,
it?
you don't have to have CBCT, but it makes your life a lot easier. If you have a roadmap before you treat a tooth, you know if there's 1, 2, or 3 canals. It just saves you a lot of time. If you open up a case, and you are searching for an MB2 canal, I can probably search sometimes if I don't have a scan for some reason. I can search maybe 20 minutes and waste time, and there is no MB2 canal maybe. If I have a CBCT, I'll spend 20 minutes doing something else because I know there's no MB2 canal. If there is an MB2 canal, I'm going to chase it, and I might use more time to locate it, but I'm going to deliver a higher standard of care of treatment to that specific patient. So to cut a long story short, in my opinion, I think a CBCT is one of the best things that a general dentist can buy, because I find, or we find in our practice, and I find on courses and when we scan patients, so much additional pathology. 30% more pathology is found on a CBCT than on conventional radiography. I think the best thing that a general dentist can do for a patient is to do a checkup, maybe every 2 or 3 years with a CBCT. And I think that CBCT will pay for itself if you start getting your practice to that. And when patients see a CBCT, especially a full CBCT, they see their skull, they see you spend 5 minutes with them. They've got never problems to pay for that, because it blows their mind, the thoroughness that you actually examine their teeth. And root canal treatments, there's so many failures around. You can pick up so much work in your practice. or just to make a decision. Should this tooth come out? Should it be retreated? What's the size of the infection? I astonish myself every day. Today I had a case that I couldn't see any pathology on the periapical X-ray, nothing. And when I took a scan, it was just mind-blowing how large it is. In fact, I decided not even to re-root canal treat the tooth. It has to come out. So yeah, I think CBCT is amazing for everyone, not just for type of specialist practices.
Okay, so, next question. I think this relates to where the canals might split along the route for multiple canals. If there's no access to magnification, what are the treatment modalities available to adequately treat scenario C, which I think is where it splits closer to the apex?
There is no treatment modality. Then you have to refer the case out. Or if you're really sitting in an area where you don't have anyone to help you, and there's periapical infection, I would probably extract the tooth. If there's no periapical infection, you can probably try and get away and closely monitor the tooth. But you know what? I've been doing root canals treatments now for 20 years. I can tell you now, if there's a root canal system that's missed, it's going to make pathology at some time. There's very few, even if the canals join at the apex, that is not a guarantee that you will not get periapical infection. I mean, CBCT has taught us so much of failure in root canal treatments. Probably, if I look at upper maxillary molars, 90% of them that I scan has got a missed MB2 canal, and there's infection around that root. So to answer your question, you have to have the right equipment, the right skill. Otherwise, try and find someone in your area to help you. If you can't, no pathology, I would probably take the risk. Maybe for a few years you'll be safe, but for long term you'll probably have to extract that tooth, specifically if it starts like at one case I showed with a large periapical infection already. Those cases is not going to heal. And I think the worst thing that you can do is probably to send that case for apicectomy, because today with apicectomies, or not today, yesterday as well, you should be doing that with magnification. You should be doing that with ultrasonic instrumentation. You should trough the isthmus. You should pack MTA, not amalgam. So in my opinion, if you send this case for apicectomy and someone just cuts the root off in theater and put a blob of amalgam at the bottom, you're buying another 3 years before the case fail again. Those of you that have registered on the Zeiss platform this week for the lectures on magnification would see that Singyang Kim is probably one of the best world authority on apical surgery, and the level and skill that he reflects is amazing compared to what we see as average daily apicectomy practice in South Africa.
Okay, and the next one, there's been a couple of people that have asked this. With regards to that premolar that had the fracture on it, how do you handle such a case when the treatment has been paid for and then you only realize there's a fracture and obviously it's failed, but there was possibly the fracture prior to the actual root canal?
Those cases have to be refunded in a way. We've got generally a policy in the practice that we will refund the patient about 50% of the fee. In fact, in that case, I refunded 75% because it was 2 weeks post-obturation. If it's a case that's long-standing, maybe for a year, that doesn't heal up and we then elect to extract it, we usually give the patient at least 50% of the money back. Because we had to pay for time, we had to pay for files, we had to pay for skill and all those things. And then they have to know this also sometimes up front, especially in high-risk cases. I tell them that I think this is a high-risk case. We are willing to do it. We take a chance together. If it doesn't work, we will refund you 50% towards your cost towards the implant or extraction or whatever you want to do. So we can't predict these things always. Sometimes we're dealing with large infection. We do a root canal treatment, it heals up. That case, I had no doubt in my mind when I did the case that it would fail. Not even the slightest doubt, because I've got a lower premolar. I had a scan. I treated it beautifully. I had lateral anatomy fault. I didn't miss a canal because I've got the second canal in the lower premolar. So I was quite proud of that case. And to see that case fail in 2 weeks' time makes you humble, but it makes you realize as well that we're dealing with biology. It's the same as implants. I mean, we take these teeth out and we say, oh, we put an implant in. I see many implants fail, and I'm not against implants. But I think we close our eyes sometimes. If an implant lose half the bone, then we say, well, it's still in the patient's mouth. Those are failures, in my opinion. We have to be fair about these things when we compare implants with endodontics as well. But we're dealing with biology, and there's no guarantee if we do implants or endo or whatever we do that it's going to survive. Just think about what goes through a patient's mouth in a year, what they subject those teeth to, what do they chew. It's actually amazing that our dentistry survive, sometimes for 5 years, 10 years, or 20 years.
Okay. We've then got a question about, if a tooth has got a periapical granuloma or abscess, are they all candidates for endo?
Just repeat that, sorry.
If a tooth has got an abscess or a periapical granuloma, are they all candidates for endo?
Yes, they definitely are. The bottom line is that we can't distinguish between granuloma or cyst, even if we see large infection areas. I don't send those patients for surgical intervention before 3 months. I will do the root canal as best as I can, and I would wait at least 3 months and check if there's any progress. If there's a reduction in a lesion, I would leave them longer. If there's an increase in size, then we will surgically intervene. But I've seen many large cases heal without any surgical intervention. I often see referrals in my practice where a patient comes in and says, can you please do the root canal? And then my dentist said, after that, the surgeon will do a apicectomy. That's absolute nonsense, because there's no reason to go for apicectomy once if you haven't given it some time to heal. There's a very good paper out from I forgot the author's name now. I've just downloaded it about 2 days ago from Endodontic Topics, where they highlighted the fact again that periapical pathology can take up to 5 years to heal. It's not uncommon. There's a very good study where they showed healing still takes place after 27 years after initial root canal treatment. So to look at a case after 3-4 months and extract the tooth because the area is not gone, obviously you don't want other symptoms. You don't want pus draining and percussion sensitivity and stuff like that. But you mustn't be in too much of a hurry in the first year or two to let those teeth go, unless you see progression and you see bone loss. Then I agree with you. But if you've done a good job and the lesion is slowly shrinking, I still think you have to wait a little bit before you in a hurry to extract those. So yes, those cases are definitely indications for root canal treatment.
Right, we've still got quite a few participants online now. I've got one more question on the chat box, but please, if you've got, or two now, if you've got any more questions, please just post them in the Q&A box. So Piet, what do you file to? And I don't know if that means what system you're using, or specifically on the system, how far you go, and then what cement is used.
Well, I'll comment on that briefly. I'm not sure if I understand the question correctly, but if I look at file systems today, my first choice in file systems is Wave 1 Gold. That's my favorite file system. I think for anyone with limited experience and even with a lot of experience, I think it's a very safe system. If I was a student coming out of university at this stage, I would stick to Wave 1 reciprocation. The True Anatomy system is quite exciting that we've launched and that we talk about, but for me that's a more specialized type of system reserved for the person with magnification, with a little bit more experience, maybe with microscope magnification. You're dealing with thinner cones, thinner files, smaller access cavities. It's more challenging to use, in my opinion. So I love Wave 1 Gold. My favorite cements would be Pulp Canal Sealer from Kerr. I like AH Plus as well. It's a little bit too runny. I'm going to be very honest about it. It's one of the products of Dentsply I don't use a lot. I would like to see that cement as a higher viscosity, less runny. And that's what I like about Pulp Canal Sealer. And then also we're facing an era now that we have to use bioceramic cements. It's not my favorite thing to use, but if you have to use a bioceramic cement, I would probably look at Total Full BC Sealer from FKG or Endosequence from the Blazer company from Shine Dental. Those are the two good bioceramic sealers. And I'm not saying there's anything wrong with it. I think if you're in a general practice, doing occasional endo and you doing single cone obturation, I think you should be using a bioceramic sealer and not any other sealer, because you'll get a better long-term result. But in my practice, at my expertise level at this stage, I'm not a keen favorite of bioceramic cement. If I use it, I still downpack the gutta percha with heat. In addition to that, I'm not really a keen favorite of just single cones.
Okay, another question. When is post-root canal treatment sensitivity to percussion a concern?
Also a good question. I think probably up to, I'm starting to worry after 3-4 months, especially if the tooth is out of the bite. Then I would probably start worrying, thinking of a crack, starting to talk in that direction. The problem is with these vertical root fractures, we don't see them on the scans, like I've told you before. Sometimes it takes 18 months to actually surface and see bone loss, and sometimes not even in that 18 months, maybe even longer. I'm sitting with an example patient in my practice that Farzana actually did a root canal on the upper molar. She had sensitivity for 1.5 years on this tooth, percussion sensitivity. She complained about it. We suspected a vertical root fracture. We scanned her probably in that 2 years about 3 times. She eventually said she's going to have the tooth out. When we decided to consent to that, then she wanted to know who's going to pay for the implant. So she wanted us to pay for the implant as well. So eventually, after a long discussion, we refunded all her money in full. And then the patient disappeared. And I recently saw the patient probably about 4 years later for another referral on a premolar. And then to my surprise, the tooth is still sitting there. And I said, what happened to this tooth? No, this tooth is now perfect. There's nothing wrong with it. We checked it on a full CBCT as well. When I look at the other teeth, no bone loss. The tooth is in perfect function now, and it's a perfect tooth. But she didn't pay a refund money back again. That's the strange thing. But to answer your question, I'll worry after about 4 to 5 months, especially if the tooth is out of the bite. You must also remember there's a condition called PDAP, persistent pain syndrome. If you Google that, you'll see it. There's about 5% of root canal treated cases that keep on having type of percussion sensitivity symptoms that no one can tell you why. It's a recognized condition now, and sometimes it's also a little bit a neuralgia related, but this is not a neuralgia. This is just a recognized condition that root canal treated teeth sometimes stay sensitive.
Okay, we're getting a few more questions coming in now, and still quite a lot of participants. When you have a draining sinus, when do you decide to obturate?
Well, let's answer the question like this. If it's a new tooth, not a root canal retreatment, if you open up the case and the case is dry inside after you've prepared it to full length, then you can obturate it, even if it's got a draining sinus. In fact, they're the safest ones to do single visits on because the drainage is towards the outside. This is not the patient that's going to phone you 2 o'clock that night and said he's swollen up and he can't live anymore. If it's a draining sinus, it relieves the pressure, so you just need to have the canal system dry. If it is a retreatment, I like to do it in 2 stages, always. But this is probably the case if I have to do a retreatment and the patient comes from very far, that I will probably obturate in 1 visit because of the draining sinus if I can dry the canals. If it's a closed lesion in a bone and it's a retreatment, those are usually the cases that flare up into a periapical abscess, and those are the patients that admit themselves in hospital sometimes and dying of toothache.
All right. How long post-operatively do you recommend crowning?
Well, that's a difficult question. I think let's go 1 step back. I think the first question you should ask is, when would you build a core? And I think the answer to that is immediately. The quicker you build a core, the better. If it's an asymptomatic tooth, I usually tell patients, leave it for 2 weeks. If it's asymptomatic, we can crown it. If there's moderate size periapical infection, and now I'm talking again CBCT, because you can't look at a periapical X-ray to make this call. If you look at a CBCT and there's really a small periapical area, and you've done a really good job, I think you can feel comfortable to crown that tooth. If it is a tooth with a large periapical infection, I would build up a core and temporize it and maybe leave it for at least 6 months to a year maybe, and not crown that tooth to see if the lesion heals and where we're going with the case.
All right. That seems to be all the questions. If anyone has got rapid fire fingers, I think we're done with the questions. And over to you, Piet. Thank you very much for such a wonderful lecture for us. A lot of the delegates are applauding the lecture, so well done.
Thank you. I see someone has asked in a chat group as well, when will Nomads Day event be hosted? Those of you that's not on the Nomads platform where we announced this, there will be no Nomads event this year. We've cancelled it. We might have an online event. At this stage, we haven't decided. I think our focus from now on is going to be more hands-on workshops, more practical focused type of presentations. And we are also considering, it's been on the cards for the last 2 years. We are also thinking of running a program for the students that just qualified under the banner of Nomad. So we are seriously considering that, and we'll probably make an announcement in the next month or 2 about that if we're going ahead with that concept. But that's where we're going to focus on, more hands-on training. Maybe 2022 we'll have an in-person meeting again. I think at this stage the risk is just too high for speakers. Can you imagine if we organize a big event and your speaker gets on an airplane and he tests positive the day before he has to fly? What are we going to do then? So the risk for us is just too high. We have another problem. We're not sure how many people will actually attend, how many people are still scared. So I think for this stage, we're going to do online events and then focus on small groups with more high-tech and more education levels of hands-on workshops that you can learn more instead of sitting 2 days in a big presentation. So ladies and gentlemen, with that, I think Misty has ended off as well from her side. I want to thank SADA for the kind invitation tonight to speak on this platform again. It was really fun sharing some knowledge with you. Like always, this is my passion, root canal treatments, and you're always welcome to email me or ask me advice. No problem, but I hope to see you in one of our events soon, hosted at the Densplus Arona Training Center. So thank you for your kind attention, and stay safe and enjoy your root canal treatments, especially on lower premolars from now on.
Thank you, Prof. Vyver and Dr. De Bruin. We will close the session now.
Thank you.
Thank you very much, Marlies.
It's a pleasure.